Good morning. Welcome to our CU Saturday session. So we had a small break last week where we took a break from the series of AI related checklists. Now after a break with the qualitative study topic, now we are back to Probast AI checklist. So Dr. Feneeshiah will be critically appraising an article and using the Probast AI checklist for a prediction model. I'll hand over to Dr. Feneeshiah.
So good morning, everyone. So today we will be looking at using Probast AI to assess the risk of bias of AI-based prediction models. So before moving on to this, we'll start off with few examples. So you're doing a night shift in ICU and you have a 65-year-old gentleman with septic shock on lactates, on vasopressors with a lactate of 6. So you wonder what is his probability of dying over that night shift. So how do you assess that? Do you take a simple guess or you use something else? So most of them us will be using something like an Apache 2 or SOFA score. Similarly, you're in your OPD and you get a 52-year-old lady with a blood pressure of 150/90 with an LDL levels of 155 and she's non-smoker. And should she be started on a statin? To assess that, you don't take a wild guess. Use something like a ASCVD risk stratification score. Similarly, you're in a ward and a patient develops sudden chest pain with tachycardia and mild hypoxia. Worst thing is you're worrying, is it a pulmonary embolism? So use something like Wells score. So Apache 2, SOFA, ASCVD risk score, Wells score. What are all of these? These are basically some risk prediction scores. What exactly do they do? So they have multiple variables, clinical variables of multiple sorts. With some sort of a mathematical algorithm or a model, they predict the probability of an event. So this is what is called a risk prediction. So for that, you use risk prediction models. So what is a prediction model? It's a mathematical equation. It combines both multiple information from multiple predictors or input features from observed or measured from an individual, and it predicts the probability of a diagnosis or a prognosis of a particular outcome. So we have two types of prediction. One is you predict the diagnosis. You have patients who you suspect a certain disease. There are certain clinical symptoms and signs. You order lab tests, imaging, and then you predict the outcome of the particular disease or not, if the disease is present or not. Prognostic prediction is little bit different. So you at starting point you have the patient with a diagnosis or something of a prognosis. So you predict using your lab test, patient characters, imaging, and then you predict the long-term outcome. This is more of a longitudinal prediction. So there are two types, diagnostic and prognostic prediction modeling. So how are these models built? Traditionally, using mathematical equations, there is an established relationship between a predictor and an outcome. So usually through either a logistic regression or a Cox proportional hazards model, this relationship is established and you kind of interpret the outcomes based on that. Nowadays, increasingly, we are using AI-based prediction models. So these models learn what is the pattern from the complex data which is provided, and they give the prediction. So few examples are random forest, gradient boosting, and neural network. So these models are usually complex and less transparent. We don't know what is happening inside the model as such. So what is the problem with this? So there is a problem of bias in this AI-based model. One thing is overfitting. So when the sample size is too small and when you're using too many predictors, so predictors are something like the parameters on which the model is predicting your outcome. So if there are too many predictors and if the sample size is too small, the model may not generalize. It will kind of by heart what it is and try to fit it. So that is something called as overfitting. Data leakage. There is so if the model learns from the results, it's like cheating in an exam. So you know the answer and then based on that you give a prediction without using the variable of interest. Next, sometimes these will not be validated. So usually we need internal validation and external validation. Most of these models are not externally validated. And there is incomplete reporting of this performance. They ignore the calibration and clinical usefulness. All of these terms, calibration, validation, overfitting, I'll come to that in a short while. So for all of this, you need some sort of guidelines to assess what is the risk of bias. So for that, what is being used is Probast plus AI. Earlier, there was Probast only tool, which did not include AI algorithms. In 2024-2025, Probast AI was introduced, which assesses the particular articles in terms of 4 domains. One is they look at the participant and data sources, they look at the predictors, they look at the outcomes, and they look at the analysis to ascertain what is the risk of bias. So these are all the questions and the domains to which all of this has to go through. So there are signaling questions under each domain, and there are 4 domains in this. So there is a separate model for model development, and there is a separate one for model evaluation. So if a study involves only model development, you use the checklist only for this model development. If it involves something like external validation, internal validation, you use risk of bias using the model evaluation. If the study involves both of these checklists should be we should go through that. So this is the model development checklist, and this is the model evaluation checklist. And how do we rate? For each signaling questions, this is how we rate. Yes, probably yes, no, probably no, no information and not applicable. If there regarding concerns in a domain, it's rated as low concern, high concern, or unclear concern. So let's move on to a case scenario. So there is Mr. X. He's a 72 years old gentleman with diabetes, chronic kidney disease stage 3B. He undergoes an elective major abdominal surgery that appears to be uneventful. On post-op day 3, he develops acute kidney injury and sepsis. He requires ICU admission. At this subsequent mortality and morbidity audit, all these records were reviewed. There was no clear technical error which was identified. They also feel that the care was appropriate and all the protocols were strictly followed. So the discussion now shifts from what went wrong to can we actually predict this earlier beforehand. So in response, the head of anesthesia proposes implementing an AI-based perioperative risk prediction model to identify high-risk patients and earlier to prevent similar complications. So before they start adopting and buying that model, they turn to you and ask, how do we know that this model is methodologically sound, free from bias, and applicable to our patient population? So this is the question for today. So for this, I use this meta-analysis, prediction of complication and prognostication in perioperative medicine, a systematic review and Probast assessment of machine learning tools. So today the structure, how we assess through this would be, first we look at the quality of systematic review using CAS questionnaire. Then using one of the studies which is used in the systematic review as such, we use a Probast AI to see how is the risk of bias in one of the studies. And then we will move to the results and how is it generalizable to our population. So starting with a CAS questionnaire, we look at are the results of the review valid? So did the review address a clearly focused question? So research question here is what is the impact of machine learning on predicting the perioperative medicine morbidity and mortality? So the PICO statement, here the population is the perioperative population. They included patients who are more than 18 years of age, with outcomes being mortality risk, systemic complications which include respiratory complications, cardiovascular complications, AKI, infection, etc., and ICU admission, anesthesiology risk, and prolonged length of hospital stay. They included both retrospective and prospective studies. These were the ones which are published worldwide, and they are in English language. And the date limit was from January 2000 to 2023. And the exclusion criteria, they use non-English language studies and the pediatric studies which involve patients of less than 18 years of age. So I feel the non-English language studies could have excluded potentially certain studies which were published not in English. So this is somewhat a language bias here. And the intervention here is an artificial intelligence or a machine learning technique to analyze perioperative data. And the comparator was previous perioperative studies. And the main outcomes were mortality risk, systemic complications, ICU admission, prolonged length of hospital stay. Additional outcome was anesthesiology risk stratification. So did the authors look for the right type of papers? They included appropriate study design for prediction modeling, which were retrospective and prospective cohort studies. And this include adult perioperative population, which is age more than 18 years of age, from 2000 to 2023, and which were English language publications. So in this prediction modeling, we may not have that much RCTs because this is a new concept and all of these were done on cohort studies earlier. So do you think all the important relevant studies were included? So they searched the databases Scopus, Sinhal, Cochrane Library, PubMed from January 2000 to 1st July 2022. They included only English scientific literature. They did not follow up from reference list or use a personal contact with the experts or contact for unpublished studies, or they search for non-English language studies. So I think they have not included all the relevant studies. So when we look at the Prisma flow diagram, so they identified 9,856 records, and out of which, after removing the duplicates, they got 3,297, and of which 3,194 records were excluded, mostly for the studies being a non-perioperative study, non-machine learning, non-AI, and few were because it was from pediatric population, animal study, preclinical study, editorial or commentary, and 12 non-English language studies were removed, and totally 103 full article text were included in the systematic review. Did the review authors do enough to assess the quality of the included studies? So they got 103 studies in total, of which they classified them into 1, 2, 3, 4, and 5. So model conceptualization studies were a total of 1 study, and most of them were retrospective study with model internal validation, which was 76, which was the majority. So most of them did not externally validate this study, as I said earlier. And there was 1 randomized study which was included. And 5 independent authors did the risk of bias assessment using Probast tool. So what they have stated is that Probast AI, which is a recent checklist, was not available at that time. And the risk of bias for the studies which was included were done based on Probast tool. And Cohen's kappa agreement was calculated between the authors, and it was 0.7. So I have used one of the studies which was included in the systematic review, which is multi-center validation of machine learning model for pre-operative prediction of post-operative mortality. So with this study, we will assess the risk of bias using Probast AI. So looking at the PICOT statement, this study had a population of around 4,54,000 patients who are over 18 years of age who have undergone non-cardiac surgeries in 4 independent institutions. So the index model is they made 2 types of model. One is a conventional model. So before this starting, what is a model and what are the predictors? I would say, like if you're given a list of ingredients and you're asked to cook something, the list of ingredients are the predictors. And how we are trying to cook it, that is the model. That's the method through which the predictors are analyzed to get a prediction. Okay. So an index model, they use 2 types of model. One is a conventional model. For the conventional model, the input variables, the predictors which they used had demographics, lab parameters, and type of surgery. And then they also used a lab model where they separated the lab results alone. So all of this, these two is comprise the index model. So they compared with an XGBoost model based on ASA PS class, which is American Society of Anesthesia Physical scoring class. So the outcome is in-hospital mortality within 30 days after surgery, which they extracted as a binary outcome based on the last mortality rate. And the timing was 30 days. And the setting, it's a multi-center tertiary hospital using retrospective EMR data for adult non-cardiac surgery. And they use pre-operative clinical risk prediction for mortality in adult non-cardiac surgical patients. So this study involved both model development and model evaluation. So first we will look at model development. What is the risk of bias? We will first look at the participant and data sources. We look at the quality of data first, where the appropriate data source is included. So the data source is a retrospective electronic health record. So there were 4 centers which were involved. One is the Seoul National University Hospital, which is SNUH, Borame Hospital, BRMH, Yuva Women's University Medical Center, which is UMC, Azan Medical Center, which is AMC. So almost between 2000 to 2019, all of these data were collected. And most of the patients were from SNUH and UMC, whereas BRMH and AMC had like 32,000 and 66,000 patients. So they have stated the data. So it's traceable, representative, and appropriate. So was an appropriate study design used? So they used multi-center retrospective cohort study with model development and external validation. So what they have done is they've extracted data from existing electronic health record. So there is no pre-specified protocol, and we don't know how these data were collected earlier, because this included data from 2001 itself. So there is no, the study was not done with a specific purpose, and they have extracted it from an existing EHR. So the probability, the concern for a data quality exists here. So, did the inclusion and exclusion of the study participants result in a representative data set? So, the inclusion criteria is participants with 18 years of age who underwent non-cardiac surgeries from 4 independent institutions. The exclusion is they excluded the patients who underwent heart surgeries, organ transplant, and neurosurgeries, and excluded whose final clinical course was unknown because of lack of follow-up. But the individual breakup of participants who were excluded because of these reasons were not stated anywhere in the paper. So, there is a concern if they have excluded a large volume of patients just because they underwent heart surgeries, organ transplant, and neurosurgery. So I've given probably yes. So another thing, concern regarding quality of selection of participants and data, it's a low concern. So because the individual participants were, individual breakup of excluded participants were not stated, but however, the overall concern is low. And applicability, for us, we as we include a lot of cardiac surgery, neurosurgery, and transplant population, we may not generalize it for those settings. Just for non-cardiac surgical patients alone can be applicable. Next, we'll move on to the next domain, which is the predictors. So what are these predictors? So predictors are these input variables which you use to assess the probability of the outcome. So what are the variables which are given? So those should be like well defined, they should be measurable, they should be handled carefully. So whatever measures they have used for this definition, measurement, that should be explicitly stated so that we could try and replicate the similar model in our setting. So we see how far it is defined here. So the problem with the predictors are they can be inconsistently measured. For example, if we are checking BMI, the components are height and weight. So it depends on how robust the person is checking the height and weight. There can be missing data, subjective variables. If it is involving a gradient of scale, so for some between mild and moderate limitation, it for someone it might be a mild limitation, but for some other assessor it could be a moderate limitation. So certain variables can be subjective. What is the timing of assessment for these variables? Is a variable which is assessed 2 months prior to the certain event is okay or not? And what is the specific timeline which they are accepting should be explicitly stated. Then there is data leakage and feature selection. Out of these two terms, I'll come to that subsequently. So looking at the study, where the predictors defined and assessed in a similar way for all the participants. So what I've given here is the predictors which they used and what all problems that can arise with this. So age, sex, and BMI. For BMI per se, it can be subjected to inter-observer variability. Regarding white blood cells, hemoglobin, platelet count, and electrolytes glucose, there can be minor variation which can differ with the autoanalyzer. Regarding BUN and creatinine, the enzymatic methods versus Jaffe method, the different labs can use different methods to assess that. And this can vary. Albumin also, there is a different dye binding method which can produce different values. For GOT, GPT, the upper limit of the normal varies different in the different systems. PT, APTT, it's highly reagent sensitive and it's subjected to lab variability. The other variables were like type of surgery, type of anesthesia, emergency status of surgery. And then there is ASA PS class, which can still be subject to depending on who is recording that. So these were all preoperative assessment recorded from EMR. And before deciding which predictor to include and what all to not to include, they actually extracted all the predictors and they removed the highly subjective predictor. And they removed highly missing predictor and they removed predictors with inter-hospital difference. One of the predictors which they said they removed was a troponin I. And the subjective ones which they said was central venous catheterization assessment and arterial catheterization assessment. The detailed breakup of what all predictors that were removed were not given. So we don't know if something was removed which could actually have a bearing on the outcome. And the assay harmonization procedure was not explicitly described. And the timing window, as in between what point do they accept for the test to be included, is also not specified. And that interlaboratory measurement protocol is standardization is also not detailed. So I've given probably yes. Was any pre-processing of predictors similar for all participants? So before moving to that, what exactly is pre-processing? So that is what is done to the predictors before model training. What are the adjustments which are done to that existing predictor data that counts as pre-processing? So there can be handling missing data, variable exclusion, feature selection, encoding categories, transformation, and standardization. So we see what is a feature selection. So when you look at the data, you'll get lot of predictors which can be used as a predictor variable. So which one is important, which is not important? That is done by something called feature selection, where they remove the unwanted filters. For example, age, creatinine, albumin, and which ward they are. Maybe the ward they are admitted may not give a predictive value as such. So in feature selection, all of these unwanted variables are removed. Some common methods are filter method, wrapper method, and embedded selection. Filter method is something you see the correlation statistics before the model and exclude the variable. Wrapper method, they try using combination of the variables. Then the embedded one, the model itself trains on it and ranks whichever is important and removes the unimportant ones. So what was done in this study? So the missing values, they handled by median imputation. So they did not specify if it was used on the training data set or validation data set or to the entire pool data. And variable exclusion, they removed highly missing variables like drop-by, removed highly subjective variables like ease of central venous catheterization and arterial catheterization. They removed variables with major inter-hospital differences like surgery name, diagnosis. And feature selection, the process is not explicitly reported. So I've given it's a probable yes. Were the predictor assessments made without the knowledge of the outcome data? So in order to prevent data leakage, the predictors should be assessed before the outcome data, and which they have done, which is yes. Were the predictors included in the model available at the time of the model intended to be used? Yes, these are all preoperative predictors. So overall, assessing the quality, concern regarding the quality of the predictors or their assessment, it's a low concern. Concern that regarding the applicability. So in our setting, we do not routinely measure electrolytes, PTA, PTT, SGOT, SGPT, and albumin. They are done on a case-to-case basis. And the other thing is the timing of the assessment is not clearly specified. We'll move on to the next, which is outcomes. So where the outcomes defined and assessed appropriately, they measured in-hospital mortality within 30 days after surgery. This is extracted as a binary information on the last mortality rate. The deaths outside the hospital is not captured here. So they have not linked to a national death this death registry where they could capture whatever that has happened outside the hospital setting. So I have given a probably yes. Were the outcomes defined and assessed in a similar manner for all participants? Yes. And were the outcome assessment made without the use or knowledge of the predictor data? Yes. And was the time interval between the predictor assessment and outcome assessment appropriate? I feel it's appropriate. And the quality concerns, low concerns regarding quality, and applicability also low concerns. So looking at the analysis, describe the number of participants, candidate predictors, and number of outcome events. The total number of predictors were 27. And for the pool data, the total number of events is 1,200. While looking at events per predictor, we get 44, which is a good number. And the total number of participants were around 450,000. But for the individual models, these SNUH, AMC, UMC, and BMRH, these are the 4 institutions which I mentioned earlier in the participants and data sources slide. These correspond to the different hospitals. So for an SNUH, the events predictor is 22, AMC 5.8, UMC 11.7, BMRH is 4.18. For AMC and BMRH, you can see the values are low, so there is a concern for overfitting. So we look at the demographic variables. So most of them were around the age of 50 to 60, and the females were around 55 to 60%. And the center reports higher females because they had more gynecological surgeries. And the BMIs were around 23 to 24. And all parameters were around the same range here. And when we look at the 30-day mortality, it was between 0.2 to 0.4%. Is it similar to our data? I'll come to that later. Based on the studies done in India, our mortality range for an elective surgery ranges between 1.5 to 2.5. For an emergency, it goes up to 25%. And here the surgeries also, most of them were general surgery, bar orthopedics, bar gynecology. The other surgeries were less. And most of them had general anesthesia. Describe how the prediction model was developed. So the modeling techniques were four. One is logistic regression, random forest, gradient boosting ensemble, and deep neural network with 5 hidden layers. And the data set which they obtained from each hospital was split into 6:2:2. 60% data they used for training, 20% for validation, and 20% as test samples. And regarding this deep neural network, they had 5 hidden layers with ReLU activation, batch normalization, dropout of 0.5, cross entropy loss of function, and parameters optimized to minimize loss. So what are these 5 terms? This seems so unfamiliar. So we'll look at what a deep neural network is first. So deep neural networks, this is supposed to mimic a human thought process. So for example, if I give you 100 pictures of faces and tell you to detect how many of these faces are smiling, you just don't go by the data as in the angle of mouth is separated this many distance apart. That will not possibly give you who are all smiling. You look at other facial features also. How are the eyes? Do they have some extra wrinkles when they smile? So those are the thought processes which are happening in our brain without our knowledge. So this is supposed to kind of mimic all of this. So there are multiple layers between the input and the output. More the layers are, the more the model closely mimics to the um, actual thinking process. So these are the layers. And the other thing is, the problem which can happen is they can take the noise also and they can amplify. That is something called ReLU activation, that is rectifier limited unit. So what the prompt that is given as a part of building is that if there is a strong signal, take it as positive. If there is a not so strong signal, ignore. So that is called ReLU activation. So the model takes only the strong signal and not the noise. And the other thing is batch normalization. So for example, we know what is SGOT, SGPT, we know what is albumin. Your SGOT, SGPT might be in double digit always. Your albumin will be a to a double digit separated by a decimal. So for a model, it's always an albumin of 3.5 is inferior to an SGOT of 35 because 35 is more and 3.5 is less. So how do you rectify that? So these are expressed as terms in terms of the average value. So if the patient's albumin is 4.5, the model will probably say it is if you consider 3.5 as average plus 1 above that normal range. For SGOT also, if you set the median value as 35 and if you get something as 36 plus 1 above the normal range. So it kind of, so what goes inside the model is that plus 1 plus 2. So plus 1 plus 2 will be similar across both sides. So it does not look at the mere number and justify, okay, this is greater than that. So that is something called batch normalization. Dropout is, imagine there are 100 people in a hospital. 50 of them does not turn up for work. So the hospital should be capable of running as efficiently as the remaining 50. So in order to train the model to do that, 50% of the neurons, what they call, they turn it off so that it works on the other 50% and predicts it. So overall, when it predicts the particular outcome, it's balanced. And cross entropy is a reward business. It's like giving chocolate when you do good things and punishing when you do bad things. So this goes in the other way, like punishing when you do bad things. So how far is the model predicting your high bias? Like if it is high risk. So if the model predicts high risk and then there is actually a high risk, it's given a reward. So if the model is actually predicting low risk for a possible high risk, it depends on the extent of the mismatch that is giving. They give a higher penalty or a lower penalty. This is to correct the model from performing in a not so acceptable way. So these are the things which they do in a deep neural network to mimic the thought process of a human as much as possible by the machine. So before moving on, I've mentioned four model things. So what are these four things? So logistic regression, as you know, we measure the estimated mortality based on the patient factors and you calculate the probability and you give certain weightage to certain factors and you predict the overall risk. So there are other models like random forest. So random forest, as we know that forest has individual trees. Here, this random forest will have individual decision trees. For example, this is a single decision tree. So if you're age more than 70, you classify as high risk. So likewise, in a random forest, there are multiple trees. So each tree will give you a risk probability. So for example, there are 4 or 5 different trees and you give the individual patient data. So the data goes through every tree and each tree will be like whether it's high risk, low risk or so. Overall, the combined probability, how many of these trees are mentioning high risk? How many of these trees are mentioning low risk? That is calculated and then there are limits which are set up. So if something like more than 50% of the trees, if they say high risk is high risk. So then after the risk threshold, you get the final prediction. So here there is a single tree. Here there is a forest of trees. Based on the information from every single tree, the final prediction is calculated. So XG boost is little different. There were a forest of trees. Here there is only one tree. And this tree is a constantly evolving tree. So it learns from its prior errors and makes a different decision. So initially, if it is predicting something low, so based on prior errors, there are more parameters which are added, like creatinine, sodium. So it learns from all of this and makes a final decision. So this is a single tree, which is evolving tree, which is evolving based on its previous mistakes. Then deep neural network, as I said earlier, it has layers of network to mimic as close as possible to your natural brain thinking. So how are these performance measures calculated and identified? Few of these things are calibration, discrimination, classification, and net benefit. The two things which are described in the study are like calibration and discrimination. So we'll go to that. So how they calibrated it, they did a 10-fold cross validation. So what is a 10-fold cross validation? So there is a data set. It is split into 10 parts. Okay, so 9 parts where like the model trains on the 9 parts and it learns all of this and it is tested on that one part. What they do in this 10-fold cross validation is each fold gets to train on, so each one fold is tested on based on the data from the other 9 folds and an average score is looked at for the final performance. So they did this 10-fold cross validation for this calibration plot. So calibration plot is like how good is the risk compared predicted risk from a model matches your actual risk. So that is mentioned in a calibration plot. So as we can see, this is a calibration plot which has predicted risk on the x-axis and the observed risk on the y-axis. This diagonal line has its slope close to 1. This is the if this happens when the prediction matches the reality. So on multiple observed risk, the prediction risk is plotted here. So for example, if the actual risk is somewhere around 40%, here the model is predicting something like, when we draw down, it's something close to 38. So here we can see if you take it as at 40%, the model is actually predicting a lower risk compared to what is actually observed. When you see something like if the observed risk is around 65%, we see it's predicting 60%, which is a lower risk. So in this model, they did a 10-fold cross validation and they tested it on a data from SNUH and they generated calibration plots. So here, when we see the predictive value and the actual fraction of positives were positively correlated, and that AMC and EUMC, the mean predictive values, there was a tendency to be overestimation of plots. So this is the calibration plot here. So here the values are given in terms of like 0.2, 0.4. So for example, if the Actual risk is 0.2. Here is a fraction of positives. So what is the predicted value? When the risk is 0.2, the model is predicting something around close to 40%. So when the when there is a lower frequency of outcomes, the model is actually predicting lower. As and when it increases, it is kind of overestimating here. So for example, if the observed risk is around 0.5, we see it is giving something around 0.8. When there is 50% risk, it's actually increasing by 30%. So these two models, the AMC and EUMC, are kind of overestimating the risk when it is coming to a lower risk, when it is going up. Whereas when you see BRMH, it is staying close to the actual one. So this is calibration. The other thing is discrimination. So how much is the model separating the patients who had an event from those who are not having that event? So one thing is you can do it with ROC curve, and the other is precision recall curve. So because the events are very less, they are using a precision recall also here in addition to ROC. So what is a precision recall? So recall is basically your sensitivity. So how good are we catching those who are going to die? That is your recall, which is given in your x-axis. Precision mainly is your positive predictive value. How trustworthy is your high-risk prediction? So for a good precision recall curve, it is close to your right upper corner. So this orange line is among these three, the one with a better precision recall would be the orange ones. So in the study, when we look at the ROC curve, the XGB boost model and the logistic regression had good ROC compared to the other models. And when we look at the precision recall, the area under the curve was high for an XGB model. Similarly, this is on the data with AMC. Here again, logistic regression and XGB had high AU ROC. And overall, both DNN and XGB have similar AU PRC. In EUMC dataset also, it is almost similar. And in BRMH, the XGB and logistic regression have higher AUROC. And here the LR has high AUPRC in BMRH dataset. Was there evidence that the sample size was reasonable? So for the pool dataset, the events per predictor is 44, it's okay. But for an individual model, AMC and BMRH, it is 4 and 5.8. So there is a small risk for overprediction. Where continuous and categorical predictors handled appropriately, the continuous variables were scaled using standard scaler of skit-learned package, and categorical variables were input to the model via one-hot coding. Here again, we see a lot of unfamiliar terms in this slide. So what is a standard scaler? So as I described earlier, like for a model, 70 is more than 1. But you know that creatinine of 1.7 is bad as such with our knowledge. So how do we convey this to the model itself? So this is calculated as a value from the mean. Like if you keep the mean age as 50, the model gets age as probably plus 5. And you keep the mean creat at 1, if the creatinine is 1.67, the model perceives it as 0.67. So it's not only the mean, there are multiple other imputation values where they could put the values which looks almost similar. One hot coding is for a binary outcome. So usually if a event of question is present, it's marked as 1. If it is not present, it's marked as 0. So the categorical data is changed into 0 and 1. That is mostly one hot coding. And describe missing data on predictors and outcomes as well as methods used for handling these data. So the mean proportion of missing predictors were 16 and 19. This is disproportionate across all 4 models. The SNUH and AMH had 3.7, 5.3, whereas EUMC, BRMC had 16, 19. And the missing data was like at random, like few centers did not record BMI, few centers did not record type of anesthesia. ASAPS grade was missing in EUMC. Certain laboratory tests were not ordered for in BRMH. So they did not identify a specific pattern at which there is missing data. Mostly it was dependent on the centers. And they used median imputation for missing values. This shows how much of the data is missing and what are those data. So when we see SNUH, it had almost data from all patients. AMC is okay. UMC did not have BMI and ASAPS type. When you see this and this, it's mostly white. BRMH did not have most of this lab values. Whether participants with missing or censored data handled appropriately in the analysis, probably yes. The missing data regarding the outcome is not explicitly stated. That's why I've given probably yes. So if methods to address class imbalance were used, was the model or the model predictors recalibrated? So what is class imbalance? So to train a model, if there is equal number of cases and controls, it can learn like 50% from the cases, 50% from the controls. But in a real world data, especially when the outcome events are very less or more, what is done is something called undersampling and oversampling. So for if there is an imbalance in the data set, so the origin so one arm has less amount of events and the other arm has more events. What they do is undersampling, randomly select data from this to equalize the other arm. So that is undersampling. Oversampling is, for example, one arm has more data and the other has less data. They kind of resample within the same data set and to increase it to the other, to increase it in par with the other arm. So that is oversampling. So here they used SMOT and random downsampling. So SMOT is for oversampling and this one is for downsampling. So, but after this, the models were not recalibrated. So where the methods used to address potential model overfitting, they used data splitting. So they used data splitting and they had separate training, validation, and test data. So the data which is used for training is not used for validation or for testing. So it was all separate. And then they use tenfold cross validation. They use bootstrap resampling. And in the deep neural network, as I explained earlier, they use dropout of 0.5, batch normalization, and ReLU activation. So they use methods to address potential overfitting. So what is overfitting? So when the sample size is low and if the predictors are high, the model learns every single thing and it learns the noise also. And finally, when you're trying to test it in a different data, it may not perform well because it has learned too many complex patterns which will not be applied for the other data. It will learn all the noise. So that is something called the overfitting. So if the model is an overfitted model, it will not perform well when they are doing it in a external validation setting, when they are using it on a freshly new data. So concern regarding quality of analysis. So the EPV varies across the hospital model and there is moderate missingness into hospital. And they did not do recalibration following SMOT and downsampling for class imbalance. And they did not do a decision curve analysis, which is to see if there is a net benefit in doing all of these studies. So far we have looked at model development. Overall, it looked like a low concern model. So now we see how it happens in model evaluation. Model evaluation, they did external validation of the model. So there are data from four models like SNUH, AMC, UMC, and BRMH. Each data was externally validated with the other three models. This is a schematic. So again, we'll use the 4 domains. So most of the signaling questions are same. Because the data they have used for validation is also the same, there might not be much difference in the domain 1, 2, and 3 here. So for risk of bias, they used appropriate data sources, appropriate study design. There were little concerns regarding the inclusion and exclusion of study participants. Overall, the risk of bias is low. So when we look at the predictors, they were defined and assessed in a similar way, but there was little concern in how the predictors were measured because it was not explicitly reported. There was pre-processing which was similar, and it was assessments were made without the knowledge of outcome data, and the predictors included in the model was available at the time the model was intended to be used, and overall there is low risk of bias. And outcomes are also there is low risk of bias as I said earlier. So when we look at the analysis part of it, was the model evaluation based on only apparent performance avoided? So what is apparent performance is the model, so it is tested on the data which it is trained. So generally they don't do that. So you use either an internal validation or external validation. So here we have got external validation data. So it is not, the evaluation is not based on the apparent performance. Was there evidence that sample size was reasonable for an external validation data set? So for a prediction modeling using AI models, at least there should be 100 events per model for the model to learn the data properly. So here, all these four had at least 100 events. So the external validation sample size is reasonable. Were the participants with missing or censored data handled appropriately in the analysis? Yes. And if methods to address class imbalance used, was the evaluation done in a dataset without imbalance correction? Yes. And was the predictive performance of the model evaluated appropriately? Yes. So this is the external validation results. So this side, you towards the extreme left, you get the models which are trained. So here, and this is the test model. And these are the external validation report. For example, a model which is trained on SNUH dataset, when it is tested on SNUH data, you get an AUROC of 9.94. When it is externally validated on an AMC dataset, there is 0.927, and on EUMC dataset 0.94, and BRMH dataset 0.908. So it is again 94% good, and the confidence intervals are also precise. So this is a calibration curve I discussed earlier. So the risk of bias overall is low. So overall judgment of the quality and risk of bias for both development and evaluation, it has low concerns. Regarding the applicability and for the development and evaluation, again, there is low concerns. So this is something which is given in the meta-analysis for this specific study. So the checklist which the meta-analysis authors used were Probast checklist. It's not Probast AI. Here we have used Probast AI checklist. So the differences which we have got it's in the domains of participants and the outcome. The other two predictors and analysis, we have almost scored the same. And this is for the applicability in terms of participants, predictors, and outcome analysis. So they have used the Probast checklist, whereas we have looked at the whole article using Probast AI. So what was the overall risk of bias in the study? They have used Probast again, and they have mentioned like 90% of the studies have unclear or high risk of bias in total. So moving back to the meta-analysis, if the results of the review have been combined, was it reasonably to do so? They have not combined the results because it was too heterogeneous, and there was 90% were rated as having high or uncertain risk of bias. Now looking at the individual study, like the overall results of the meta-analysis was not combined, but looking at the individual study which we have looked at, all the four models exhibited superior prediction performance in terms of AUROC and AUPRC compared to the ASAPS class. And the XGBoost model delivered a best performance, and the SNUH model and EUMC model with large amount of data delivered better performance when externally validated. So how precise are the results? The confidence intervals are narrow and the results are precise. And can this be applicable to our local population? One thing we have to consider is the ethnicity. So these were done on Koreans. And while looking at Indian population, we further need further studies. And the baseline mortality risk, which we saw, was like around 0.2 to 0.4. Whereas based on the data from these three studies, there is 1.9% for a pure abdominal elective surgery, 2.4 for any elective surgery, and 23.8% for an emergency surgery. So our mortality risk is slightly higher compared to the Koreans. And we have the model reported multiple lab parameters, but then what are the comorbidities? Like, was there a heart disease, CKD at baseline? That has not been captured in the model. Where all the important outcomes considered, they considered a hard outcome, which is 30-day in hospital mortality. They could have considered quality of life, days of ICU admission, and ventilator-free days. They could have also linked the data to the National Death Registry and captured the overall admissions in terms of in-hospital admissions alone. Are the benefits worth the harm and cost? We cannot tell because there is not much data on the clinical impact, cost effectiveness, and decision curve analysis, and there is no external validation outside Korea. So regarding the cost effectiveness, why are we concerned is that using an AI model would require a lot of cost in terms of manpower required, in terms of electricity, the system required for running, and all the technical stuff will contribute significant cost to the existing healthcare system. So if that has been explicitly described, this would have been it would have been useful. So coming back to our question, before adoption, they turn and ask to you, how do we know this model is methodologically sound? So overall, these have 90% high or uncertain bias. This can't be used in our setting because this model is not externally validated in our setting. Second, already these have high uncertain bias, and most of the studies contributing to the systematic review also were not externally validated. So the information, if you could get from that study, also cannot be fully trusted for us to make a decision to implement the thing in our setting. So summarizing, so we looked at what are the predictional models in first. Then we looked at the systematic review, which used Probast to assess the risk of bias. We looked at various components like what the models are, what are few things like calibration, discrimination, what is AUROC, what is AUPRC, and we also looked at what is feature selection, which is used in AI process. And we went through the Probast AI checklist for model development and model evaluation. And finally, we have concluded saying there is more AI is an option, but then there is a lot of work that has to go through before we could use this option in our setting. Thank you.